Hey guys, so today we'll be discussing about infectious diseases. So this one will be specific to urinary tract infections, which falls under the minor ailments. So the presentation I'm going to be going over will kind of just follow the Canadian guidelines. So it might be different from where you guys are, but hopefully maybe the concepts will still kind of be the same. So urinary tract infection, cystitis refers to the infection in the bladder, which tends to be the lower UTI symptoms, while pyelonephritis refers to infection of the kidneys. You'll find that it's more common in women due to the shorter urethra, and so usually you'll see this most likely usually in younger women, and it occurs usually as a result of not wiping your bum properly after you go to the washroom, because that pushes the E. coli closer to the urethra as well. So you usually want to counsel patients um, to wipe from a bottom to up motion as well. And also other factors can affect it, but usually that seems to be the most common with younger girls as well. Um, Usually you'll refer to it as uncomplicated if there's no other factors. If it occurs in men, this is usually defined as complicated, and this is again due to the fact because men will tend to have the longer urethra. So the most common suspects, I spelled that wrong, but that's fine. It's E. coli, Klebsiella pneumonia, Enterococcus species, Pseudomonas aeruginosa. If you get that one, you're gonna have to use specific antibodies to treat that one. Staph pseudococcus and Candida from indwelling catheters. So just if you notice the similarity between everything is that these ones all tend to be, um, well, except from the staph one, they tend to be what we call as gram negative. Oh my god, it's really hard to write this. Okay, there we go. Gram negative. So these ones tend to be gram negative species. And so hopefully if you know your antibiotics well, you'll know what kind of antibiotics kind of to target these. So for example, you will unlikely see a lot of beta lactams used to treat these kind of species. So symptoms, you'll get the classic pain, stinging, and burning. You'll get the increased urinary frequency and incontinence. Sometimes blood in the urine can be present, and the urine can also be cloudy and foul smelling as well. Pyelonephritis will differ from the uncomplicated if there is fever, low back pain, and nausea and vomiting as well. So in terms of the pain, stinging, and burning, you may also need to ask questions to the patient, such as if they had any, if they have been sexually active or anything to do differentials from an STI or STDs. But generally, these tend to be the common symptoms that you'll see in the urinary tract infection. But the key thing you should really keep out lookout for is just these ones right here, the fever and the low back pain as well. Because as we said earlier, pyelonephritis is infection of the kidneys. Uh, kidneys. I hope you like that writing. So, what are our treatment options? So, generally, this usually resolves within a week, and you don't want to usually treat unless the patient is symptomatic, because as you know, antibiotic resistance, right? So first line we have nitrofurantoin 100 milligrams BID for 5 days, and the way I remember that, so if you work in a pharmacy, you'll likely see the drug brand name known as Macrobid, and you can remember BID for BID dosing. And then macro is spelt with, it's a bit of a short, but macro is spelt with 5 letters, so you can remember that for 5 days of therapy. Another thing to just note about macrobid is or nitrofurantoin, sorry, is you'll notice that it comes in a um, monohydrate form and then a macrocrystal and monohydrate combination form. So hence the name macro, so macrocrystals. So the macrocrystal form, that's a combination, that's dosed BID, But if you were to use the other nitrofurantoin, which is just the monohydrocrystals, mono, um, it's going to be a QID dosing. You'll hardly see this one on exams, to be honest, because everybody is just going to go with the assumption that you're referring to the macrocrystals, as well as the macrocrystals higher efficacy as well. You also have your trimethylprim, sulfamethoxam. I'll just call it TMP-SMX because I always have trouble pronouncing it. BID for 3 days, and the one way you can remember that is the brand name is called Sulfatrim DS, but I usually think of it as like unos, dos, and tres for 3 days, and then dos for the BID dosing. And then the next one we'll have is Monoral, um, which is basically Monoral is the brand name. Phosphomycin, which is basically a powder that you're going to dissolve in a glass of water and then drink for one dose, usually 3 grams. So Monoral, mono for one dose. So this one's really good if a patient has difficulty swallowing. However, it's not as strong as these two options. So these ones will usually be your strongest options as well. Now, if there is a reason patient can't take any of these, for example, maybe a sulfur allergy in your sulfamethasol, alternatives would be. Oh, forgot about to say that. So complicated UTI is usually similar therapy, but you'll give it for 7 to 10 days compared to these ones. But sorry, so back again to the alternatives. You'll have something like levofloxacin 250 to 500 milligrams daily for 3 days, or your ciprofloxacin 250 milligram BID for 3 days, or your cephalexin 500 milligrams BID for 5 to 7 days. So cephalexin also falls under the beta-lactams, but it does have some activity between some gram negatives as well. And these two are technically like your powerhouses. So these are your fluoroquinolones. Okay, so pregnancy and breastfeeding. Um, you don't usually want to treat it unless it's confirmed on 2 consecutive cultures, even if it is asymptomatic as well. And the reason for that is why you want to treat asymptomatic UTI in pregnancy is you want to reduce the risk of pyelonephritis, which is, as we discussed earlier, the one in the kidneys. So basically, your beta-lactams such as cephalexin and phosphomycin are safe throughout the entire pregnancy. Nitrofurantoin is only safe in the second trimester of pregnancy. And this is due to because it can cause hemolytic anemia in other trimesters. Some therapies may use it as prophylaxis just before gestation, but generally, second trimester is the way to go for this one. You'd want to usually avoid it in the first and third. Fluoroquinolones should definitely be avoided as well, and that's because they have a negative effect on the cartilage and bone development. And SMX and TMP should be avoided in the first trimester, and that's due to the antifolate activity. Um, you can use in the other trimesters with caution. Uh, Generally, if you see this, I would try to avoid it if you can, even if you can use it in other trimesters as well. But all therapies are safe in breastfeeding as well. Actually, just to go again to the SMX and TMP, you might see it in rare cases, such as if a patient is HIV and they may use this even if they're pregnant for prophylaxis against pneumonia Geravici. But that's pretty much only the rare occasion where you'll see it throughout the entire pregnancy. Okay, this one is chronic prostatitis. It's the inflammation of the prostate in men, and this is usually due to P. aeruginosa. Now, P. aeruginosa is one of those ones that you can only use a specific number of antibodies against. So that's like your cefidime, ceftriaxone, um, and then piptaz or aminoglycosides. Or in this case, you're most likely going to use fluoroquinolones. So this is characterized by fever, lower UTI symptoms, and sexual dysfunction. And like I said, this one is usually only you're gonna see in men. So that you're gonna treat with the ciprofloxacin and levofloxacin for about 4 to 6 weeks. And if there's fluoroquinolone resistance, then you're gonna go give them the TMP and SMX treatment. Now, pyelonephritis, as we said, that's the upper infection of the kidneys. If it's mild to moderate, you're going to give fluoroquinolones for 10 to 14 days. If there's resistance, then you want to use the SMP TMX, amoxiclav, or just trimethoprim on its own. Just important to note is nitrofurantoin is not used, and that's because it can only reach it does not reach the kidneys and is only localized to the bladder infections as well. So it's really highly dependent on the kidneys to be flushed out of the bladder. So if there is renal impairment, then you want to avoid nitrofurantoin. But in general, like you'll never see this one in pyelonephritis because it won't reach and it won't do anything. For severe cases, we're obviously going to use IV, and this is going to involve the double A's, which is the aminoglycoside and ampicillin. You'll generally want to switch to the oral ampicillin once the patient is stable. Now, this is really important. If you see a test like from the cultures that it comes up as ESBL, which is extended spectrum back to beta lactamase, which basically is very high bacterial resistance in um, in your cultures, you'll want to give carbapenem in order to treat it. Now, there is a bit of a 1% cross-reactivity with penicillin allergy. Um, you hardly get tested on that, to be honest, but it's just kind of good to know. You're going to basically monitor the patient just to watch out for the penicillin allergy, but 1% is pretty low. Um, if the patient is pregnant, you'll want to give cefotriaxone, which, as I said earlier, also has the Pseudomonas aeruginosa coverage as well. So this is just the adverse drug reactions. Um, like I said earlier, you need to avoid renal impairment. It also causes hepatotoxicity, pulmonary toxicity, peripheral neuropathy, and seizures. Honestly, you probably won't even run into these ones that often, so I wouldn't even be too concerned about it unless the patient presents with those symptoms. But it does cause a bit of urine discoloration as well. So that one you'll probably run into more often, which is a yellowish brownish color. And the way I kind of remember that is if you think back to if you ever see the macrobid capsules, they kind of have the yellow blackish. That's kind of how I kind of remember that it has the yellowish brownish discoloration. Okay, SMX and TMP. So you'll want to avoid these in a person with sulfa allergies. Trimethoprim is okay to use on its own. Rash, diarrhea, thrombocytopenia, renal impairment, potential cause hypoglycemia with sulfonylureas. But I think most importantly, you should watch out for hyperkalemia. So if a patient is on this and they're taking an ACE, for example, or spironolactone, you'll need to monitor the potassium levels just to make sure they don't go hyperkalemic. It may cause a false increase of serum creatinine due to increased tubular secretion of creatinine. And that's more important for monitoring of your renal function. And it can also increase methotrexate levels as well. And then phosphomycin, not too much to know about phosphomycin other than it causes diarrhea and vaginitis. And then metoclopramide may slow absorption as well. And that's because metoclopramide's a prokinetic agent as well. Or antiprokinetic agent, yeah. All right, thank you. And yeah, good luck on your exams.